Please settle down and put your mobiles inside. Approaching the last lecture. The issue is about the electrolytes, how kidneys treat the electrolytes and they maintain the balance. This is today's issue. Look at the board first. The datas of two cases are given there. Okay, just analyze case number 1. Okay, look at the data. I don't know if you can see it properly or not, but I think it is visible. This is case 1 and this is case 2. All right, so two datas are given. Let us see the data one by one. The first one is up. Okay, you see a case of a patient who approaches the hospital and he presents with this kind of data. On investigations you find this picture, and now you are concerned about whether your data is normal or abnormal, and if it is normal it's okay, and if it is not, then what is the problem? So what do you see here? What is your idea about the first case? Just looking at the electrolyte picture, you are not doing anything special, but you are looking at electrolytes. Okay? Okay, now you are looking at the concentration. So the first thought which comes in mind is that what is normal? Is it normal or not? And if not, then what is abnormal? It means that you need to know about the normals. Okay, at least you should have an idea. As a medical student or a doctor, you should have an idea that what level is a normal level of the common electrolytes. Even though it is given, usually the lab give you a range, but since you are studying and you have done it before also, you may have some idea about it. So what do you think about data number 1, the case number 1? Do you find anything abnormal? Do you suspect anything? Sodium. Okay, so your comment is starting from sodium. What do you think about sodium here? It's a bit low. Okay, so if you're saying it's a bit low, then maybe you have a cutoff point where you can say it's low or it's not low. So what is your idea? Almost that sodium should be from this to this.
I think sodium should be from 140.
If you take 140 as an average value, which is usually given, a single value when it is given, it is usually like 140 or 142, it is written in the books. But that represents an average value. If you are considering the average, then your sodium should start from below, a little below. So let us go down. 135 is usually accepted. Different labs, different values, but 135 is mostly accepted. Okay, and then the higher upper limit will be? Yeah, it's from 135 to sometimes they say 145, sometimes they say 150, up to 150 they can take. Okay, so it's a big range of sodium. It's not a slight tilt of the scale here or there that making it 134 or making it like 141 makes it abnormal. No. Okay, so it's a good range really. Okay, sodium is so abundant, it's kathir actually. Okay, so it doesn't easily go into an abnormal state. Considering the value of 135 as you are saying, and we are accepting it, what do you say about sodium now? Tell me more technically, what will you say? Yes, you'll say, seems like a case of hyponatremia. All right? First thing that you see. Now, scan down and see. Further scan the data. Do you find anything or you say it's okay? Sodium? Okay, hyponatremia. Anything else in the data? pH. What goes wrong with the pH here? Normal, nearly normal. Okay. What is your normal pH? Yeah, usually books give you a range which is acceptable as a normal range, and 7.35 to 4.5. Okay, but yes, okay. Let us say like this. So if it is so, then the pH is normal or abnormal? So anything else? Bicarbs or potassium or chlorides or anything? Yeah. No idea? No comments? Okay. Come down to case number 2.
pH is not
Okay. For the rest, again it's silence, right? Leaving pH and sodium, you will not make any comment.
Because they are normal.
They're normal. Because you know about them now, because we have discussed that. But what about the other things? Potassium. Okay, so now, a step forward. Now looking at the potassium, the focus is potassium now this time. In both cases again, compare and say, potassium, what do you say about potassium? Maybe hypokalemia. For saying it maybe, what provoked you? What level? Again, you will consider that 3 to 5. 3 to 5. If you are taking it 3 to 5 and then you see both cases, then what will you say about potassium? Both cases normal. Okay. Well, potassium has a very tight range really. Okay, a very narrow range, very sensitive. A slight change in the scale can cause a disaster. So you have to be very careful in making a comment about potassium, not like sodium. Sodium is different. Sodium you can move here and there and still you are normal. But potassium, it's a problem really. A little shift and anything can happen. So, roughly speaking, what should be the starting level of the potassium to call it normal?
3.
3 would be a little low. 3.1.
3.5.
Okay, 3.5. Nus. We'll start from 3.5. Talata or nus. Well, yes, usually the range which is mentioned is from 3.5. Most of the labs, most of the reference values, 3.5 to. Well, I did say that it's a narrow range, but I did not mean that it's so narrow that you have to move from decimal point 3.1 to 3.5. This is it. No, it's not like that. Come on. A little more liberal. You can go a little forward. Yeah, it's okay now. A range of 1.5 actually. Okay, 3.5 to 5 is usually potassium. Now look at it again. If you say, yeah. Which one? Case 2. So in case 1, your final picture is? Case 1, your final picture is? Okay, and case 2, what is your final picture? All right, okay. What will be the clinical consequences if you have case number 2? What is your idea? What would the patient be presenting? Yeah.
I think the patient is hypertensive.
Hypertensive. Okay, so you are making the link of low potassium with hypertension? That's why, Abdullah, you are saying case number 2, hypertension, it's coming in your mind. So you are making a correlation between low potassium and hypertension. This is what I am getting from you. Adrenal disease. Okay, interesting. Adrenal disease, if you are saying, what kind of adrenal disease? Yeah?
Adrenal cortex. Aldosterone.
Aldosterone. So let's pick aldosterone. How do you link aldosterone and potassium?
Aldosterone causes
Yeah. It. All right. So aldosterone is acting on potassium, you are saying, and it is causing its secretion and promotes its excretion. Okay, like this. Secretion, which may lead to excretion, or definitely adding to excretion. Okay. What if you have potassium and then it is acting on aldosterone? What is your idea now? Take it other way around. Potassium now acting on. First you are looking from the point of view of aldosterone. What is aldosterone doing to the potassium? Now you are seeing what is potassium doing to aldosterone. Make a sense. When you have a high potassium, what will happen? Stimulation of aldosterone secretion. Okay, and if there is a low potassium, okay, and why would there be a low potassium if you are linking it with the aldosterone?
Maybe depends on the sodium.
No, again I am staying at the link of aldosterone and potassium. What would be the level of aldosterone when you see a low potassium level? If you are high or low, decide one thing.
High aldosterone and low.
High aldosterone and low potassium. Usually this is the picture. Okay. Alright. Because low potassium will do what? It can. Okay. But if it's a disease of adrenal cortex, then what kind of a picture do you suspect? He's saying adrenal cortex disease. It means aldosterone is the primary thing. Alright. Now you are thinking from aldosterone point of view and looking at potassium. So aldosterone would be high and potassium would be low. Will it be? Yeah. Alright. Okay. In some cases when you are starting from potassium, and if potassium is low, then secondarily what will happen to aldosterone if there is no disease? Right? Low. So you are looking from 2 points of view. Are you getting this? Okay. Alright. Anyway, the idea is that potassium is low. Again coming, one could be the endocrine picture. I am asking clinically what can happen. Clinically.
Maybe sodium, potassium, ATPase, and that's lead to decreased calcium, that influence to the cardiac, and that's lead to decreased
Contractility of what? Of heart. So you are focusing qalb. Okay. Is the heart only region which is affected by the potassium? It will be. It will be. In hypokalemia, heart is affected, the rhythm is affected, contractility is affected. Good point. Okay. But before heart, what else can happen? Or what other things can happen? Potassium, low potassium. What will be the feel of patient? What will be the clinical picture of the patient? Definitely he doesn't know about his arrhythmia, or he doesn't know about the contractility of the heart. It will come late. But what is the subjective feeling of the patient who is presenting to you and who has hypokalemia? Not that level, maybe a little low, because that is not a very low level. 3.2 is not really causing symptoms. But if the level is really low, you're talking about hypokalemia. If it's going down below 3 or 3, okay, then what do you think? What can happen?
Constipation.
Okay, constipation. All right. Maybe. Why? Because now you are thinking about calcium. Okay. Constipation is due to slow movement of the GIT, right? Okay. And slow movement of the GIT is due to?
Relaxation.
And what is the link between smooth muscle and potassium? Okay, so we are going back to the basics actually. Cardiac muscles, smooth muscles, and we did not talk about that. About what? Skeletal muscles. So let's talk about skeletal muscles. So what do you think will happen to skeletal muscles? Yeah. See, why is potassium important for the skeletal muscles? This is a question. Why is potassium important for the skeletal muscle?
It causes the contraction of the skeletal muscle.
It causes the contraction of the skeletal muscle.
Hypermobility.
Just rephrase you are close, but correct your statement. Contraction is caused by another ion, you know that. Okay, yeah. But before contraction, what happens? Okay, yani. Between neurotransmission and between contraction, what is happening in the muscle? Action potential. So, is there any link between of action potential and potassium? Isn't it? One of the phases. It means you are affecting the action potential. If you don't have action potential proper, will you have contraction proper? It's a very simple thing. Okay. So it means potassium will cause a defect in muscle excitability, which will affect muscle contraction, isn't it? But not directly, through the excitability. So it's about the muscle excitability that is affected. What do you think about sodium? First case, and clinically. Okay. Let's suppose if it's an acute case, he comes with an acute problem. All of a sudden this has developed, not a long time. So in that case, again you are coming back to the muscles. So what will happen to the muscles?
No action.
Action potentials may be affected, okay? But if you are comparing potassium and sodium, which ion changes will be more sensitive for the action potential, sodium or potassium? Potassium. Why? Very little margin of potassium really. So potassium changes are first to affect excitability. Sodium, when it really goes down here or it goes up there, then it can cause changes. So when you are considering cardiac muscles or skeletal muscles, so which ion would you focus more first? Potassium. Okay, it's an immense importance of potassium which is coming in, isn't it? Anyway, we need to know about both ions very correctly. Sodium has a big margin, potassium has a little margin. Potassium is clinically more evident and involved in cases of abnormal pictures, clinical presentations and symptoms. Sodium also, but when sodium goes very low or very high, then it will happen. Okay, so very quickly now we are coming to the basics. So why we are looking at the electrolyte disturbances? We are looking at sodium, potassium, we are looking at chloride. Chloride is normal in both cases. We look at the bicarbonate and pH, but that comes basically in the acid-base disorders or the acid-base disturbances, on which we'll have a tutorial inshallah, a very interesting one. We'll have it together, no problem. Now what do you see here in the first slide? Now you know. If it goes there or on the other side, things will go wrong really, okay? So here it's 135 to 145, which you were saying, and I said that it may be up to 150, many labs say that. It's okay. 145, 150, sodium will do nothing really, okay? 135, going below 130, sodium will do nothing really. Symptoms are not produced easily when you are going down or above. But symptoms come very easily when potassium goes down or potassium goes up. Okay, if the potassium is going up, what will happen? Arrhythmias are the main problems. Okay, it's not the case of the muscles this time here. You are still considering heart. Okay, so the problems will go with the heart. Others also, but heart mainly. Okay, look at the review, which we have an idea about already, and we have seen sodium processing in the nephron. There are different areas where sodium is reabsorbed after filtration, if you remember, okay? And these areas, if you see, okay, the major area, definitely everyone knows how evident it is from the picture. Proximal, taqriban 2/3, 65%, 66% it's coming from, okay? Second thing, I'm sorry, it's very light and you're not having a visibility. It will improve now a little, okay, and you can see. So obviously, what about the other areas? What is the second important area that you have? Thick loop of Henle. These two will cover almost the major part of the sodium, the percentage of the reabsorption. Do you see that? Okay. The rest is depending on the hormones or the other things. The first two, 65% sodium and 25%. So, yeah, it's, yeah, thick ascending. That's making together 90%. Do you see any involvement of hormones in these two areas, proximal tubule and the thick loop of any major issue of hormone? Minor hormones are acting, I am saying that, okay. But any major hormone which is coming and acting? No. So it is hormone dependent or hormone independent, generally speaking? So most of your sodium reabsorption is independent of the hormones, or it may have a very little effect if any hormone is there. Okay? Now in the last part, in the distal convoluted tubules and collecting ducts, will it be hormone dependent or hormone independent? If so, it will depend on how much hormone is present. Is it available or not available, present or not present, and then you will see that. And you can see different 5%, 4 to 5%, depending upon the hormones you are looking at. Okay? What do you think about water? Even though we are not talking about water, but water goes side by side. So again, if I use a word that we have an obligatory reabsorption of water from some areas of the nephron, can you identify those areas which are giving you obligatory reabsorption of water? Proximal. Proximal, after proximal? Okay. Collecting is obligatory. It depends on hormones. Hormone maujud, water will be there. If not, not. Okay. ADH, yes. Aldosterone, yes. They are helping, isn't it? But it's not the hormone independent. Obligatory means obligatory. It's lazim. Okay. You have to absorb a specific percentage of water. So first is definitely proximal. All major part of it, we know. What is the second one? Oh yeah, it's the descending. You remember the thin descending limb of the loop of Henle, it does reabsorb water and it increases the osmolality, if you remember. So water to some point, it's reabsorbed from here also. Okay, and then after that, water goes down. Okay, from thick loop and from the early distal tubule, no, it's not. Again, it comes back when you start the late distal tubule and then collecting ducts. But then it is hormone dependent. Okay, all right. So if I say we have two types of water reabsorption, one is obligatory and other is facultative, which is dependent on factors. Which one will be facultative and which one will be obligatory? Okay, so collecting ducts and late distal tubules, you will make it facultative, hormone dependent, isn't it? And hormone independent or obligatory, you will make it from. Okay, very quickly, just a recap of pictures. You will see the pictures. Just focus the pictures, please. Okay, I am not saying anything. You are looking at the sodium processes. You are traveling through a nephron, the journey through nephron, different parts of nephron, and you will see what is happening one by one. What is this part of nephron? Okay, have a quick look and see what kind of processes are happening without any comment. Okay, just have a look. Luminal side, basal side, look at sodium. Your focus is sodium, okay? Because we are talking about sodium, all right? Did you see that? Okay. So what do you see here? Proximal tubule upper part, proximal tubule lower part, early or late proximal tubule. You divide the proximal tubule into two parts, the upper portion and the lower portion, still proximal tubule, but slight change in processes in handling of the ions. Okay, now what do you see in lower down proximal tubule? Okay, all right. And you see sodium, you're focusing sodium, all right? the movement of sodium, how sodium is getting reabsorbed. We are talking about the sodium, okay? Okay. What is this? Thick loop of, very good, thick ascending loop of Henle. Very nice. Now you see, what do you see here? Very good. What else do you see here for sodium? Okay, paracellular, but very little really, because this is not giving you a very good idea. Paracellular could be there, but it's almost negligible. If you forget about this one, the upper one, and looking at the cell only, what two main processes do you see for sodium? Yeah, one is the triple transporter and other is counter transport. Out of these two, which one is giving you more reabsorption of sodium? Triport is giving you more sodium because it's a very efficient worker over there. All right. What do you see here? Distal tubules. So what do you see here? Co-transport, sodium and chloride co-transport. You remember that, right? Yeah. What do you see here? Yeah. It's the late distal tubule, which is more like collecting duct, cortical collecting duct. Okay. So do you see sodium movement here also? But how is sodium moving here? It is. Okay, but what kind of process is happening? Counter transport is happening for the sodium potassium pump, right? Okay? Well, sodium potassium pump is everywhere. Any cell, every cell, sodium potassium pump is there. From the luminal side. Sure? In the picture. What is the main happening? I'm not saying there would be some sodium hydrogen also there, but in this picture what is shown here as the main thing? Sodium potassium pump on the back side, leave that. From the front side, what is there? Do you have a pump shown here on the luminal side? No. What is then shown here? It is a channel, first of all. If it is a channel, then what kind of process is that? It's diffusion. All right? Is it a facilitated diffusion or a simple diffusion? It's simple diffusion. You don't see any protein, you don't see any attachment. Well, protein is there because channel is also a protein, but it is opening only and the ions are freely passing inside. Okay? So special sodium channels are there. Look at the significance really here, because in pharmacology you see some drugs which block these channels, and if these channels are blocked, sodium will not be reabsorbed. If not, what will happen? Oh yes, so one of the mechanisms of diuresis is produced by one group of drugs which is acting on the distal tubules, late distal tubules in this region, and those are special diuretics. Triamterene and amiloride. I don't know if you remember that or not, but you have done it in pharmacology. There are some special sodium channel blocker drugs. These are the sodium channel blockers which block the sodium channels in the late distal tubule. Okay, so diuresis is produced. All right. Okay, and when you are going here, in case of the triple transporter blocker, what kind of diuresis is coming in your mind? Loop diuretics are working. The most powerful diuresis, we call it the high ceiling diuretic, having the highest efficacy. The maximum effect seen with any diuretic is coming from this group. So the most powerful diuretic action is coming from here. Okay. After that you have on the right side early distal tubules. What kind of diuresis do you? Oh yes, so it means you have got different levels. You are starting from thick loop of Henle, and if you want to produce diuresis, the most powerful one It's coming from loop diuretics. After that, you have early distal tubule. Well, you have another very important group, very effective, useful group, which is thiazide diuretics, a big group, excellent group. And then you have some channel antagonists or channel blockers, which are coming lower down in your late distal tubules. And what are